Thank you so much, Dr. Alex Blum. I wanted to welcome you and appreciate your taking time with us today to talk about value-based healthcare and specifically alternative payment models. Looking at your background, really exciting because you've had time in the administration, in the innovation group at Centers for Medicare and Medicaid Services, CMMI. You've had time at Mount Sinai, Aledade Consulting, and now at Galileo. Super exciting background. And one of the things that's really interesting, I think, for all of us watching the show is that you've been at this from a couple of different perspectives. You're a physician, you've been in the policymaking sphere, and in consulting and working directly with payers as well. So we're really excited to hear the different facets that you can bring to the discussion. So can you talk a little bit more about your background and the types of novel alternative payment models that you've seen?
Sure. So I am a pediatrician by background. Decided very early in my medical career that I didn't want to care for one patient at a time. I wanted to work at a population level and was interested in kind of working with marginalized populations. And then once I understood that, kind of sought to orient my career in that direction. So I was, as you said, I went through a couple fellowships, including being at Mount Sinai, where I got steeped in kind of data and a health services research fellowship. And then I ended up at the Innovation Center at CMS, which is a research and development shop. And when I was there, it was kind of the beginning. Super exciting. They have $1 billion a year to kind of model test innovations into the delivery system. And at that point, we were just kind of funding interesting ideas. So it was like we were on the receiving end of all kinds of super interesting payment and delivery reform concepts and kind of placing bets and funding ideas that would lower cost to Medicare and Medicaid recipients. Fell in love with delivery reform, payment reform, decided to go directly to a payer, where I was the chief medical officer of a small startup health plan. And that's really where I was started to put into place some value-based paradigms myself. So I started talking to providers about paying them for outcomes and value instead of just fee-for-service payments. It was really kind of nascent, very simple. Like we chose a couple metrics. It was like, if you hit these metrics, we'll bonus you on achieving those. Spent 4 years at that health plan. And then I decided to kind of pivot into a startup. And I've been in startups for the last 7 or so years since then. So I was at Aledade for 4 years, a venture-backed healthcare startup that aggregates independent primary care providers into accountable care organizations and ACOs. And I help lead the business development team there, meaning like establish payer contracts on the behalf of our providers. Did that for 4 years and then I'm now at Galileo, which is Dr. Tom Lee's startup organization. Tom founded Hippocrates and then One Medical, and now this organization. It's kind of like 21st century primary care. I'm doing the similar work around value-based care. So establishing payer partnerships and putting in place payment contracts around improving quality and outcomes and not just paying for volume.
From you talk about so many different kinds of organizations, and we're reading in the healthcare news all the time, and it's always value-based, value-based, value-based. You define what value-based healthcare is and what is truly an alternative payment model.
Sure. I mean, the standard payment model is fee for service, which is literally paying for services, which incents all the wrong things, which is volume and more services. And so value-based payments are those that are paying for improved outcomes, like improved health, reduced costs, improved patient satisfaction. It's kind of like the triple aim that CMS, Don Berwick established at CMS, and has kind of oriented the field around value for those three pieces. And so there's lots of different ways to structure value-based arrangements, but my career has been built off of the concept that the primary care provider, the PCP, should be the quarterback of care. They should be the center node by which care is controlled. That's kind of principle number one. Principle number two is like historically that individual is underpaid. Like typically it's 5%, 5 cents of every healthcare dollar roughly goes to the PCP. It should be more than that because this is the person that can control 80 to 90% of the entire healthcare dollar. So let's figure out how to pay them more. Principle number three is and don't do it in a fee-for-service manner. Do it in a way that makes sense. So you align finances with the primary care doc so that you're paying them as the patient gets healthier and reduce cost, all those savings don't accrue to the health plan, to the insurance company. They should be shared with the primary care provider. And then there's tons of nuance around those principles, but like those are the core tenets by which I kind of think about value-based care.
From one of your past experiences, if you want to pick one, maybe two of specific kinds of models that you were involved with designing and or just that really aim to connect payment, connect money to those incentives that you just described.
To back into answering that question, like first, the question assumes, and it's right, that there's like a continuum of payment reform. So if like fee for service is on the far left of like lacking at 0% or on the like continuum around value-based payments, I think global capitation is on the far right, meaning like 100% of the risk is pushed off of the health insurance plan to a provider. And, basically just to give that a tiny bit more nuance, what that means is like the health plan takes, let's call it 15 cents of the dollar just to run the health plan, or maybe a little bit less even. And then 85 cents of every healthcare dollar goes 100% to a provider. And if there are any losses, the provider takes it on the chin. If there are any savings, the 100% below that 85 cents is kept by the provider. So in the middle is a whole lot of like stepping stones to get to global capitation. And so you have pay for performance on the left. So you're just paying for tasks and provider behaviors. You have like bundled payments. So you're paying for like an orthopedic surgeon, one bucket of money for a hip replacement, or an OBGYN, is a classic example for like a pregnancy. What I do is more what I would call total cost of care agreements. And what that means is like a quote ACO deal is a sharing in savings, and that can involve risk as well. So the way that works is a primary care provider is essentially paid fee for service throughout the year. Like every service they do, they still are submitting bills, claims to the insurance company. They get reimbursed on a fee for service manner throughout the performance period. At the end of the year, you look at the cost for the cohort of patients that provider managed compared to a benchmark, a starting point, and you see if there's a delta, and you adjust the endpoint for inflation and for risk. Meaning like it's not literally dollar to dollar. Because you have to account for the riskiness of the patient. You have to say like, okay, you got an influx of like super sick patients, so let's adjust kind of the amount of money that we expect should be spent on those patients. And if there's a delta, if after adjustment for inflation and risk, it's below the benchmark, then there's savings. And as part of the deals I establish, you like negotiate ahead of time, a priori, what percent of the savings stays with the payer, what percent goes to the provider. Likewise, if the endpoint after adjusting for risk and inflation is above the benchmark, there's loss. And you negotiate in the contract ahead of time. Do we agree that some of the loss moves from the plan to the provider? How much of the loss? Is there a limit on the loss? So I would call those like total cost of care ACO deals, because it's premised on fee for service with a true up at the end of the year on savings or risk. And those can get, a lot of risk can be passed within that paradigm. Like those can get you really, really close to global capitation, where you can structure the deal to say, 100% of the risk, upside or downside, is passed to providers. So they're just getting paid fee for service throughout the year. And at the end of the year, depending on where you land compared to the benchmark, 100% of losses, 100% of the savings could be in the contract passed to the provider group. So it really gets you far down the payment reform paradigm, that continuum.
What you've described, I'm starting to see a lot of that in the U.S. as well as in the Netherlands, the shared savings types of models. Here's my question, because you just laid out the continuum of fee for service to a total global cap. A lot of the hypothesized benefit behind changing a payment is around psychology and behavior modification, either of patients or clinicians or both. How does that, it seems to me that one of the potential challenges with that, or criticisms, is that that's still fee for service. And so the doc doesn't actually change how he or she provides care because they're still fee for service. To what extent have you observed is that potentially true or not proving out to be true?
That's why health plans will in general say like they're fine with ACO deals, but they want to like incent behavior change by including some downside risk. I think the deal should include downside risk, and it can be, and it should be not too substantial to like wipe out the primary care doc, but just enough to be like motivating. Putting even downside risk aside, like the opportunity, there's a lot of money to be made in even upside only, what I would call like a gain share ACO deal. Again, fee for service premised on like sharing in the savings. And so the whole idea there is like, so basically, I think there's three components that you need to really succeed in any of these deals. And what we're talking about is only one component. Like it's not enough to just get the contract in place, because the vast majority of providers in the United States, once they get the contract in place, won't know how to be successful within that contract. They literally, like, I'm a doc myself, I'm a pediatrician. If I'm in the clinic seeing patients every 20 minutes, I have like no time to reorient my clinic to doing proactive outreach to patients to figure out like, well, who was seen in the emergency department? Let me like reach out to all those patients to make sure they don't get readmitted. Let me do a data analysis to figure out who's the at-risk and high-risk patients, and that put processes, workflows in place to like proactively reach out to them. So you need more than just the contract. You need something like the tech tools in place to do the workflow changes I just described. And even that's probably not enough. You probably also need resources, like people helping coach you through this. And then if you look across kind of like the healthcare startup space in the United States, you see lots of companies in each of these three buckets. Lots of companies doing the contracting, lots of companies doing the tech, lots of companies doing like in-person kind of consultative support. And there are a couple companies that do all three. Like that's what kind of the Aledade model where I used to work is based off of. So just look at some of the results of physician-led ACOs that are all fee-for-service based. The data speaks for itself. This is like Michael Chernow who's published on this, others. Like we've moved beyond just like how do we feel or our opinions about this stuff. The data's out there now, and it shows that physician-led ACOs are highly successful.
Could you drill into some of the detail, whether it's what you did in your Aledade days or initiatives launched under CMMI? Can you talk about the components of building those? You laid out the three buckets. Do you have maybe a specific example that was really done well, where you've got the contract part, you've got the IT part that enables it, and then that change management, consultative, whatever it is, that human part?
I'm essentially describing the Aledade model when I do that. That is essentially the scalable, reproducible model that they put out in their markets. And it works well. I mean, a centralized team that does the contracting, and those are like experts in doing total cost of care deals. I mean, in medical school, I didn't learn how to do those contracts. And certainly if I'm seeing patients every 20 minutes, clinicians don't have the expertise nor time nor interest to like negotiate the deals per se. And then, the physicians themselves don't have the technology nor the money necessarily to like figure out the tech piece. So that's why I think it makes sense having a company at an enterprise level kind of offering the population health tool itself. And again, I think you need like the human in-person support kind of doing the coaching. And just to be clear on that point, it's not short-term parachute in and do like, hey, here's some throughput analysis to like get patients seen quicker in your clinic. It's not that. It's long-term relationship building that moves clinics to do practice transformation. And that takes a long time and convincing.
Yeah, can you unpack the ideas or more specifics about what were the metrics or report the data that were most essential to present to clinicians who were having to implement these models, and how you went about kind of that next step? It's almost like change management, getting this data in front of them so they really were cognizant of how this worked and it impacted them directly.
It often does take some convincing of providers that it makes sense for them to get into these sort of arrangements, because what we hear from providers is like, I'm doing well, like my patients have good outcomes, my patients are sicker than other patients. And so now there's publicly available data through CMS on Medicare patients that it allows entities to like pull down that data with the provider's permission and kind of show them the numbers so that they can see, at least for their Medicare patients, how they stack up against some like regional national benchmarks. And that's been like super helpful because it gives doctors a way, like data to like wrap their head around benchmarking their performance. And then you couple that, so that gets you the first piece of like, okay, well, there's room for improvement. And then you couple that with like the second part of the convincing is like, well, look, there's a lot of money to be made in these type of deals. You know, PCPs are historically underpaid. They're like all the health plans now are moving towards these alternative payment models and gain share risk sharing deals. And look like at the track record, like all these other docs are succeeding in kind of reaping the reward of those type of arrangements. And then you just, the last piece is like, just show them the path. Like, this is how it would work. You know, this is like phase 1, 2, 3, 4 of like how we would actually push you into do practice transformation to be able to succeed in these type of arrangements.
And then is there like some routine reporting where you show them, here's how you did on these metrics, and here are the financial updates for what it's doing for you, so that they get that real-time feedback? I'm thinking about the psychology.
Yeah, I think that's kind of the old school way of doing it. Like when I was at the health plan, that's what like payers have always done. It's like, if we just show doctors the data, they'll figure it out. That doesn't work. You have to do workflow changes to reorient a practice away from just caring for the patients that make appointments to do proactive outreach, to do medical management. You have to put workflows in place that allow for those changes. That's the key here. The data is secondary. It is important, but like workflows is like by far the most important thing of how you move a provider practice to value. And then you couple that with like data. And so you make it accessible in the workflow. So it's just part of, at point of service, they understand the opportunity. So at point of service now, Medicare shows you cost data, for example, on patients. So in some of these tools, these pop health tools that providers use, you can see for your Medicare patient, the good ones can show you like, here, by the way, your patient has seen all these specialists. And like, look, your patient saw a cardiologist, and the cardiologist they saw charged $600 for a stress test. And you can see on your next Medicare patient, a patient saw a different cardiologist, despite the fact that you're in rural Missouri or wherever. You know, they saw the only other cardiologist in town, and she didn't charge $600, she charged $200 for a stress test. It's like eye-opening. So it's not necessarily data, I think, in the way you may be describing. It's like at point of service, you bake the data into the workflows to allow docs to kind of at point of service improve health. Another one is risk, right? Like you have to, all the pop health tools now allow providers to see like, remember, because I told you the benchmark is risk adjusted, right? Inflation adjusted and risk adjusted. There's only two ways to make money in these type of deals because you're not impacting inflation. Either you're decreasing the cost or you're making the risk, improving the risk, meaning you're much more specific in the coding that you're doing. So then in the pop health tool, in the workflows, you need to bake in a way for a provider to see, you know, here's the current risk score of your patient, and here's the possible risk score, and an explanation for like why this possible risk score is getting suggested. Like there are other diagnoses that other providers have been able to give on your patients. So all that's at point of service, but you also do have to do what you're describing, which is like at a more macro level to take a step back and say, you know, here's how you're performing compared to other docs in your region, or here's how you're performing against other docs in your practice or other docs in your accountable care organization. Doing some of that, being very transparent and quality and kind of utilization is super helpful to docs. And by the way, like physicians are super competitive. So using data and comparison points to drive behavior change practice change is very effective.
Thinking about the risk adjustment, you talked about that, and I had some pre-academia experience in managed care. So I know what you're talking about. Of course, it's evolved since then. But have you seen good examples where a health plan, usually I think about the health plan benefiting from the risk adjustment scores in the Medicare Advantage space, as an example. Have you seen where that's been shared well with physicians, so the physicians benefited from documenting the risk scores?
Right. So that is a totally logical question. And often as someone who sells into health plans and convinces health plans to do these type of deals, I will show them, you know, here's the population health tool, and look, like providers can see the current risk score and the possible risk score. And inevitably every health plan will say like, oh, but we do that. But again, as a clinician in the practice, if I'm seeing patients every 20 minutes and I have like 9 different health plans or more that my patients have, and each health plan like does that, meaning they expect me to log into their portal and go patient by patient, portal by portal, it is impossible. Like it doesn't work. You need one platform that's payer agnostic where a provider can just see agnostic to payer the risk opportunity. So yes, it is true that every payer basically at this point, you can get that data out of their portal if they're willing to share it. And they are almost always, especially if you take downside risk. But in practicality, it just isn't congruent with like providers is seeing patients all day long.
So the physicians want to do it, they do it anyway, but the practical part of the data entry sounds like it's a problem. I hadn't even really thought about that being the barrier. I just remember we were paying docs to bring patients in for face-to-face. This was before we had quite as much telehealth, so that they could do the annual coding of each of those diagnoses to increase our risk adjustment scores. And we paid them. It wasn't directly correlated to an increase in the risk score percentage or something.
And that still happens. Like every MA plan gives a kicker for an annual wellness visit because they think that's the visit that'll lead to improved risk scoring and diagnosis capture. And so all that is still true. And if you're seeing patients all day, every day, and you want to capture risk, you need some central go-to platform that pulls all the information into one place. So you're literally not going portal by portal.
So what are they just using that module in their EMRs, or are they just leaving that to the health plan and like they've told you they do it themselves?
Yeah, I mean that's a really good question. I think I'm a little surprised that EMRs haven't fully been built out to be like truly robust at population health management. I bet if you talk to like an Epic rep or something, they would say like, oh, but we have this module, which may or may not be true. I think, again, going back to my old company, Alidate was founded by this guy, Farzad Mostashari, who ran the Office of National Coordinator, the regulator of EMRs nationwide. And he was there during the High Tech Act and like during Obama, like really with the explosion of EMRs. And he just assumed he would find an EMR that did fantastic pop health management and then build Alidate kind of based off of that. It doesn't really exist today. So that's why you have companies like Lumeris, Alidate, others. All the risk-bearing providers in the United States have all built their own proprietary tech, like VillageMD, Privia, Agilon, Optum Care. They all have their own suite of tools that pulls the data in from payers, reflects it in a very easy manner back to providers as a one-stop shop that's payer agnostic.
When developing a contract, with all the moving parts, the roles of physicians, the roles of the payer, the financial aspects, the reporting metrics on quality or outcomes, et cetera, you have around the table employers, insurers, primary care specialists, hospital. Who are the crucial folks to have around the table if you're going to come up with an effective model that will be successful?
So the payers already have these models that are like off-the-shelf contracts. So it's not like you're going to a payer and it was like, hey, I have a great idea for a model. In fact, that's actually how I thought it worked when I first started doing this. And there was like this kind of ridiculous meeting that I went to at the very beginning with the CEO at United Healthcare in Minnetonka in Minnesota, where we had slides to explain a model. Like, here's how an ACO model works. You have like just what we went through. You have a benchmark, risk adjust the cost. And it's like we showed up, and of course, United Healthcare knew what an ACO deal was. And they now have either the payer has contracts that and these models that are pre-established, or they don't, because you're not going to be successful showing up, certainly not to like basically any health plan, but certainly not the nationals, and saying like, hey, I have an idea for a model. Just to like get on the same page, like that's the starting point.
I would hope they had physician input or input from other stakeholders when they built those, so that the providers don't feel like they're just being rammed down their throats and they're not.
Yeah, that's right. Yeah, so I know United Healthcare really well, so like we can use that as an example. So they have a whole team on the clinical side that's like a value-based clinical team that reports into the chief medical officer. And their job is to inform the models. And so, within United Healthcare, it's this humongous behemoth of an organization, but the key stakeholders at that organization that are creating these contracts, at the table, you have like clinical, you have the contracting team, which at United is called United Health Network. Like they're the contracting team, they own the network. Then you have the medical economists, and then you kind of have like the finance team, and then you have the P&L owners. And then you probably have actuaries, and that's probably the only other group that's kind of missing. But like those are the key groups in the legal team, I guess, that are like forming these contracts on the United Healthcare side. The clinical team is not the strongest voice at that table. It never is. It's like the finance team is the strongest voice. And, that it probably differs a little bit. There's variation payer to payer. But like out of all those teams, that's kind of the way it works. So they born the models and the contracts, and then either they're going to providers and saying like, hey, provider, we think you should be in a pay for performance contract, or they're going to a provider and being like, we think you should move to risk, or they have innovative providers that are aggressive, like every organization I've been in, like all the risk bearing provider groups that are now proliferated, that are coming and inundating the payers to be like, give us a risk deal. They all, like all the big risk bearing provider groups, just want to take on basically as much risk as plans are able to give. So of course there are some health plans that don't have those models established, where a provider group might have a little bit more sway in helping shape the model. But like, just to kind of answer your question a little bit more directly, in those kind of conversations, and I've only been part of those conversations, not from like a health system, like I've never worked at a health system, but one of these risk bearing provider groups that I've been a part of, you're coming to the health plan. And I've done this before where like we've drafted a model internally to say, we really think you should try this innovative thing. And we drafted that model, contracting people like me, policy people, medical economists, kind of our CEO. We all like sat down and whiteboarded out what we thought a progressive model would look like to move a provider over a 10-year period to risk. It didn't go anywhere with the health plan. Like, because again, like most health plans are just really, either the model exists and it's like they have the paper that they can like offer you. I mean, it's the rare health plan that's still today looking to innovate and create kind of interesting new payment models.
So it sounds like they've been down that road already, right? They
Yeah.
had these stakeholder conversations, they tried experiments, they tested them, and now what they have are canned on the shelf, the ones they believe work the best, at least.
Yeah. Yeah, I will say that is true. Typically, they're not creating these models anew. Now they're iterating on existing models. So you see, again, back to United Healthcare, you see this all the time. Every year, they make updates to their total cost of care ACO deals. So, like when I started doing deals with United, you could get into upside only deals where they didn't require downside risk. And like the minimum requirements to get in those deals are much lower than they are today. Now they require downside risk, and it's much harder. You have to have more members, and there's other bars you have to clear to get into those deals. So United, and I'm just using them as an example, like updates their ACO model annually almost.
Thinking about, especially since it's sounding like are starting to become more and more standardized, probably across systems or relationships between systems and insurers. I bet the contracts are starting to look more and more alike, or at least like the same handful of contracts. Can you talk about a model that you felt was really effective and how it was evaluated? What were the results like, financial outcomes, process, et cetera?
I think the easiest way to answer that is like kind of what are the right principles to use in developing these models where like payers and providers are to get them aligned. I would throw out a couple principles. One is like there needs to be enough money that's shared between the health plan and provider to motivate behavior change. That's kind of part and parcel with a couple questions ago that you asked of like, if it's built on the chassis of fee for service, doesn't this still just create the same perverse incentives? No, because principle number one of a good ACO deal is you have to have a big enough pot of money at the end of the rainbow of shared savings to reorient practices to do the proactive outreach to drop costs and improve quality and health. So that's kind of principle number one. If you buy into that principle, then there's all kind of contracting implications that exist with that. So for example, I talk to health plans who will say like, we want to put a limit on the amount of shared savings we'll share with the provider. that response especially gets triggered if I say, I want to put a limit on the amount of downside risk exposure to us because, we're not a multi-billion dollar organization like United Healthcare. Like, we got to limit the downside. And they're like, sure, but we want to limit the upside. And I try to stay at a principal level and be like, no, you don't, because you want us to knock it out of the park. Like, there should be no limit on savings. Like, a sharing and savings aligns everyone. You do better when we do better. That's tied to that principle of like enough money. And the rainbow, which is kind of like hangs with principle number 2, which is like you have to make these contracts sustainable. So in some of the contracts, you'll see, remember we talked about the benchmark and like costs, especially you see this in the fully insured and self-insured, the commercial markets. You'll see payers that say like, okay, you start here, you came in down here in your costs. Great. You had this delta the first year, but now the second year, the benchmark gets ratcheted down. So you start chasing your tail and you're like, okay, I drop costs another 5 points. Fantastic. Year 3, now your benchmark went down and and you have a diminishing return problem. So you try to convince plans to say like, no, the model needs to be sustainable. Let's just pick a North Star, a benchmark, make it fair, and let us like shoot North Star at least for like a couple years before we start adjusting down, and we can't chase our tail on a deal. And like third principle is kind of something around like sharing and data, because you can't really perform well in these contracts if health plans aren't giving the information, the data to providers. I know that sounds obvious. I still struggle with very progressive national health plans to get them to share claims and data, because I think they think it's like their proprietary information and it's just administrative burden on them to figure out how to set up the FTPC site to like share the data. You can't really succeed though in these total cost of care deals if you're not getting the claims information from the health plan. We talked about downside risk as a principle. It should be motivating, not life-threatening. That's probably principle number 4. I've written about this once in Health Affairs in a blog. I'm missing one principle, but there's 5 principles I pointed out in an ACO deal that aligns providers and payers.
I always refer people to the Health Affairs post too. That's always great. We can always add that in. I was in the healthcare news not long ago that CMS, I think they were looking at the next gen, which was what that 2016 to 21-ish period. And that the report said that CMS saved money, but every bit of it was paid out in benefits. So it kind of left the reader walking away from the story feeling like, well, it kind of worked, but kind of didn't really save the taxpayer any money. What kind of results have you seen from these, be they Medicare or CMS oriented or private, as far as what kind of percentage of savings are possible and what kinds of health improvements or pop health improvements are possible? What have you seen?
I would say that ACO program, the Accountable Care Organization in general, has kind of gotten a knock. The narrative is like it doesn't work well. You just have to dig into the data. So it's related to like the Michael Chernow comment I made earlier. Like just look at the guys out of Harvard who are publishing this on this topic, Michael Chernow and others. You can see in their JAM articles that provider-led ACOs do well. Like they're the ones who are saving money. Hospital-led ACOs are really tough. Tough meaning not very successful, because hospitals struggle because their incentives are still misaligned. Like their incentive is still by and far to fill beds and to get patients to specialists, the ones that are doing high cost procedures. Someday, I hope in our lifetime, this is going to change. But like that is definitely the paradigm right now in health systems, is still an orientation towards volume. You hear about one-off cases where this is starting to change, and that's great. They have not saved Medicare money, the hospital and ACOs by and far. That's part of the way I see the world of like empowering primary care docs is part and parcel with helping a PCP lead. They can be ruthless in medical management because they can pick and choose who they refer to. They can spend their day thinking about keeping patients out of the emergency department and out of hospital. That's kind of the way I see the world.
So you focused on the financial part, but have you seen some improvements in like the processes to take care of patients with chronic disease or the outcomes in terms of chronic disease or other things that have been really impressive?
Oh, yeah. I mean, I was just reviewing data this morning for the company I work at. 50% reduction in inappropriate emergency department visits was like a number I saw. almost a 50% increase in flu shots given in the home by my company last year. When you align financial incentives, it allows for an investment by these entities into proactive care. And it works particularly well for primary care docs who don't have the perverse incentives that like health systems have to like still fill beds, right? That's why I'm saying it's not just when I say the ACO program works for physician led organizations, it's not just cost, it's on the quality piece too. I mean, the organizations I've been part of all quantifiably increase star ratings. That is good for patients. Those are all HEDIS, those are all national based NQF HEDIS measures. We've agreed as a country, like these are the right quality measures for seniors, for Medicare Advantage patients. And the organizations have been part of it, all increase star ratings. And that's great for the patient, but it's also really good for the health plan because like the way health plans are paid is also the amount of money they get per patient is tagged to the quality that their network is performing. You can get an extra 5% on the amount of money points on the amount of money coming to a health plan based on stars performance. And so health plans, not only do they want to keep their members healthy, but like it's also financially a huge improvement on their revenue if you can improve quality.
That's a theme that we've been talking about, right? We want to align financial incentives with the health incentives so that we actually get rewarded for doing what we want to do intrinsically anyway. So that's beautiful. In closing, there's so many entities that are still early on this journey, whether in the US or abroad, and they're trying to figure out how to get started and what pitfalls to avoid, what are the necessary things to ensure greatest odds for success. What's your closing advice? Again, things you've got to do and things you've got to be very careful not to do.
The way I would suggest a provider sees the world on like moving away from fee for service into value is to think about these three pillars of value-based care. Like it's not enough just to get the finances aligned in a value-based contract. It's not enough just to get the tech, the population health tool, access to that tool to do the proactive outreach to patients before they get sick. And it's not enough just to get support from like a consultant or in-person support to do practice transformation. So you're not just making appointments with whoever calls. You really need like all three pieces, and either you do a patchwork to like put all three pieces in place. But like, I just don't see another way to move away from fee for service without having those three pillars addressed. And that's the way I see the world. And to me, I've seen a lot of success, meaning improve quality, improve health, reduce cost when all three of those components exist.
And to reiterate, pillar number one is the contract structure itself. Pillar number two is that data, EMR capability to get this data together. And three is that hands-on coaching, facilitation to put it into place and keep that in the forefront so that it really changes the practice itself.
Exactly.
That is fantastic. Dr. Alex Blum, we sincerely appreciate it. This has been a great discussion. I know that the students and colleagues are all going to really appreciate it. And we'll make sure to circle back with you later as we move farther down the road.
All right. Thanks for the opportunity.